presentation. We will begin with a case report of pediatric patient recently diagnosed with Takayasu arteritis. Next, I will provide an overview of childhood-onset Takayasu arteritis, focusing importance of early recognition. And finally, we will summarize with some conclusion. Our patient is a girl, 5 years old, comes from Vĩnh Phúc province, Vietnam. The patient presented with pain in both ankles, which was the main reason for hospital admission. 2 months ago, the child presented with bilateral ankle joint swelling and pain, relief at rest, accompanied by reduced mobility and soft tissue warm around the joint. She also experienced weight loss of 4 kilograms within 2 months, but she was febrile, no chest or abdominal pain or headache. About the past histories were normal. On musculoskeletal examination, we found the patient present bilateral ankle joint involvement. Soft tissue swelling was observed, joint warm to the touch, but no redness. Mild tenderness on palpation. Range of motion is moderately restricted due to pain. And about another joints were normal. When we examine the joint, we check the parts in the lower extremity. We found weak parts in dorsalis, pedis, and posterior tibial and popliteal arterioles in lower extremity. In contrast, the radial, the brachial, and axillary parts in upper limb are strong and symmetric. Besides, we found the fluid were hurt over the abdominal aorta and subclavian arterioles. And here we present the four-limb blood pressure measurement of patient. Normally, systolic pressure in lower limb should be higher than the upper limb. But in this patient, this reverse pattern, where ankle pressure are lower, indicate impaired arterial perfusion and is highly suggestive of large vessel involvement, possibly due to Takayasu arteritis. About on general examination, the patient was alert, no fever, and as finding was normal. And next slide is some investigation. You can see the inflammatory marker are highly elevated. CRP is very high and ESR is market price. So this finding strongly suggests an ongoing inflammatory process consistent with systemic vasculitis. And this slide presents imaging finding from echocardiography. You can see the bilateral subclavian arteriole show concentric thickening of the intimal and medial layers. And the left common carotid arteriole also demonstrates concentric thickening in the lower one-third of the cervical segment. And this slide presents imaging finding from MSCT, and there's a diffuse concentric wall thickening of lower third of the thoracic aorta and the abdominal aorta, resulting in 50% luminal narrowing. And here is the right subclavian arteriole, so evidence of intimal thickening. Right and left. And we are looking at a 5-year-old female reversed in good health who was admitted due to joint pain. She has been experiencing symptoms for 2 months, including ankle pain and weight loss. And on physical examination, we noted a weak pulse in lower extremities, and fluid were hers overlaps subclavian arteria and abdominal aorta. And importantly, there were no evidence of infection, and she had no sign of anemia or heart failure syndrome. Further imaging using MST show vascular lesions that for significant stenosis in multiple major arteries. So this case emphasizes in the importance of early detection, as vascular involvement can progressively quickly in pediatric patients. And now let's move on to the brief overview of Takayasu arteritis in children. Takayasu arteritis is a chronic large vessel vasculitis affecting the aorta and its major branches. Delayed diagnosis remains a major challenge, especially in children where early symptoms are often nonspecific. Increasing in evidence suggests that a longer diagnostic delay is associated with more extensive or irreversible vascular injury. And we summarize several studies that investigate how long it takes to diagnose Takayasu arteritis in children. And you can see the time to diagnose this vary significantly by study and country. For example, in Canada, the study reported an average time to diagnose it of 6.6 weeks. In Turkey, they found a much longer average, 4.6 months. Some cases took more than a year to be diagnosed. This study clearly highlight a major challenge. Early diagnosis is very difficult in Takayasu in children. So why is Takayasu arteritis often diagnosed late, especially in children? I'd like to highlight four major reasons why diagnosis is often delayed. First of all, the disease is extremely rare in children. Second, the early symptoms are very non-specific. And the third, there was historically been a lack of diagnostic criteria to children. And finally, the advanced imaging study like MRI angiography or PET-CT are often needed but may not be readily available in all centers. Now, let's talk about the rarity. One of the key reasons for diagnosis delay in childhood Takayasu arteritis. You can see the prevalence of TAK insurance is lower than adult. This makes disease unfamiliar to most pediatricians, and unfortunately, epidemiological data on childhood TAK remain very limited. For example, you can see in Sweden, the estimate annual incidence of CTAK is about 0.4 per 1 million individual. And for example, in Vietnam, no nationwide data are currently available, and existing information is limited to a case report. So it means that most pediatricians have little or no first-hand experience with childhood TAK. As a result, early recognition or diagnosis become extremely difficult, especially when the disease presents with non-specific symptoms. Now let's move on to the non-specific clinical symptom of childhood Takayasu arteritis. This systemic phase occurs weeks to months before any vascular sign appear. Symptoms during this test are non-specific. For example, you can see some patients have fever or fatigue or weight loss, or muscular skeletal manifestation. So often lead to misdiagnosis as infection or autoimmune disorder or rheumatic disease. This is a reason for diagnosis late. Now I'd like to highlight some findings from Brazilian multi-center study involved 71 patients with juvenile onset Takayasu arteritis. So you can see here's some constitution symptom, for example, fever or weight loss. Take about occurring in 77.5% patient in initial assessment, and the average time from symptom onset to diagnosis was 1.2 years. 1 to 4 years, and the disease progression lasts around 5.4 years. This so classic progression of Takayasu arteritis patient with begin with systemic inflammatory as the disease involved vascular side become more pronounced. And here is some clinical symptom observed in vascular side, and you can see hypertension is present 70% of cases, absent parts in 53%. And in early stage, just these signs may be absent, especially in children. More routine for limb blood pressure measurement are not commonly done in children, which make early detection even harder. And another important barrier to early diagnosis in childhood Takayasu arteritis is low clinical suspicion and underuse of vascular imaging. In pediatric patients, pediatricians often have a low index of suspicion for large vessel vasculitis, leading to delay anticipation of vascular imaging, such as CT or MRI angiography, and elevation in inflammatory markers such as CRP or ESR are non-specific, so may not strongly suggest Takayasu arteritis unless the diagnosis is active considered. And another major reason for delayed diagnosis in childhood Takayasu arteritis is the lack of pediatric-specific diagnostic criteria. And you can see the 1950 Asia classification criteria were primarily developed for use in adult population. So up to 2006, APLAR and Printo Oppress was appeared to use for children. And here is 1950 ACR classification criteria for Takayasu arteritis. And yeah, you can see some vascular signs such as absent pulses, blood pressure, discrepancy, and fluid. These features are often absent in children, especially during the early system phase. Pediatric patients fail to meet the ACR criteria in early disease, resulting in delay and misdiagnosis from several months to years. And here is the APLAR Printo of Press classification criteria introduced in 2006 to 2010 was designed for childhood large vessel vasculitis. And so let me talk about the importance of early diagnosis of Takayasu in children. The first major reason why early diagnosis Takayasu arteritis is so important is significantly lower the risk of irreversible vascular damage. By the time many patients are finally diagnosed, they already have advanced vascular lesions, and these can include several narrowing, now you know as stenosis, or even complete blockage of major arteries like renal or subclavian or carotid arteria. And when damage has progressed this far, treatment become more complex. You can see the patient may require invasive intervention such as vascular stenting or surgical bypass, or in some cases even kidney transplantation. And if Takayasu arteritis is detected at an early stage, it allows for timely medical treatment that can effectively control vascular inflammation. So have to prevent some severe arterial damage. More importantly, reduce the risk of long-term complications. For example, kidney failure or severe hypertension or stroke. So early diagnosis means you can avoid many invasive procedures like vascular stenting or surgical bypass. So another important reason for early diagnosis Takayasu arteritis in children is its impact on growth and development. When hypertension remains uncontrolled for a long time, or when the initiation for a corticosteroid treatment is delayed, children may suffer from growth retardation and delay. And finally, this slide emphasizes the critical importance of early diagnosis in childhood-onset Takayasu arteritis to reduce mortality and long-term complications. And according Miss Kinin, patient diagnosed late, so more extensive vascular damage, needed more surgical intervention, and had a poor response to response to therapy. So how to early diagnose Takayasu arteritis in children? This slide we summarize key recommendation for pediatricians in early detection and management of Takayasu arteritis in children. First, always maintain a high index suspicion, especially in children with persistent headache, blood pressure discrepancy, or weak pulse. The second is check for limb blood pressure. A difference between upper and lower extremity pressure can be a clue to large pressure involvement. And the third is monitor marker of inflammation like ESR or CRP, even if symptoms are subtle. This can provide important diagnostic clue. And finally, consider early vascular imaging, such as Doppler ultrasound or CT angiography, when finding a suspicious. Early imaging can reduce delay in diagnosis. Thank you so much.
Okay, thank you, Dr. Ha, with your very interesting presentation of a case, clinical case, and an overview on the Takayasu arteritis in children. I think there is some concern and some questions from our colleagues in the chat box, but perhaps we'll come back with these questions later. Now I would like to ask Dr. Lê, do you have any comments or any sharing on the topic or about the presentation and case presented by Dr. Ha? And meanwhile, Dr. Ha, please look at the chat box. And I think some of our colleagues would like to know more information about the case, about the clinical case that you presented, and some questions you also can explain or supplement later. Okay, Dr. Lei. Hello?
Yes, thank you, Professor Hung and Dr. Ha, with your very excellent presentation, Dr. Ha. And today I have some discussion about pediatric Takayasu, also diagnosis and treatment. Can I share my screen?
Oh, yes, I think so. Can you show it? Can you show it, Dr. Lei? Use slideshow function, please.
Ta chị không share được rồi hả? Nhưng mà share rồi không chỉ tắt được. Sao nào? Tắt rồi thì chưa screen share ra đúng không?
Okay, do you have any problem, Dr. Lei?
Yes.
Dr. Ha, can you stop your sharing? Maybe no. I see your screen already, Dr. Chi.
Huh?
Yeah, I see it, but it's not shown yet. So could you please show it up?
Can you see my screen?
Yes, I can see it, but the slide is still in normal view, not present view, not presenting view. So maybe you use the slideshow function to show it up to make it fit the whole screen. Can you do it? Tam just said that you can press F5. Please try this, Dr. Lei.
Yes.
Okay, I think you can present like this. You just move the slides and then you will talk if you cannot show it up. Dr. Chi, Dr. Lei, can you hear me? Can we move up and down to see if the slide is moving? Sandia, can you check if you can do anything over here?
Can you please put your slide in the press? Yes, that's one. Press, Dr. Chi. Kindly press. The one that we marked X. Yes, that one. Thank you.
Yes.
Can you?
Yes. Yes, it's okay now.
Yes.
Thank you.
I have some discussion about the pediatric Takayasu. We can see the early diagnosis of Takayasu in pediatric is not easy, as Dr. Ha has commented. And clinical pictures, we can see the pre-spouses up to 50% of patients with no symptoms of Takayasu disease. But in the post-NIS phase, we can see the patient has symptoms of arterial pulse and dilated arterial disease, also HR arterials because of complication of vasculitis, and sometimes the patient have other inflammatory conditions such as IBD, sarcoidosis, or polychondritis relapsing. About the laboratory test, no specific, as Dr. Ha comment. And we can see some signs on chest X-ray and also in echocardiogram. And how we can diagnose early in children with Takayasu, we have to base on the clinical criteria, angiography, abdominal, and laboratory findings. High index suspicion with often insidious non-specific symptom mimics many inflammatory conditions, blood pressure discrepancy, and hypertension. And there was some diagnosed criteria, ALA and ASA in 2000 and 2022, but not recommend for children. We use the classification criteria for childhood onset by ALA 2008. And on the ways of diagnose Takayasu, we have to exclude other causes mimic Takayasu, including infections of Staphylococcus, Streptococcus, Salmonella, syphilis, and tuberculosis. Also, other primary vasculitis such as Bisset, Kawasaki, and PANS. We also have to exclude vasculitis secondary due to SLE, spondyloarthritis, and sarcoidosis, and some non-inflammatory disorder. Various imaging modality for diagnosis and surveillance. Non-invasive technique and invasive technique. Each technique we can see the advantage and disadvantage of techniques, but in children we often approach the Doppler ultrasound on CTAs. And we can see the characteristics of homogeneous thickened vessel wall and luminance changes. Also, the late complication with stenosis and aneurysm. There are five types of angiographic classification Takayasu arteritis. How about the management? Because the rare clinical trial design, so the ALAS recommend on treatment of elder Takayasu may use in pediatric Takayasu patients. Systemic hypertension very frequent in pediatric Takayasu, as Dr. Ha talks. So blood pressure must be interpreted adequate. Treatment hypertension in children may be not respond to medical therapy alone, so revascularization requirement. We must be careful when control systemic hypertension in special cases such as significant or subclinical cerebrovascular involvement in management of systemic hypertension, because precipitous drop in blood pressure can cause major CNS damage due to decreased perfusion. Endovascular and surgical intervention in some cases in children, we often require in aneurysm or dissection of renal artery stenosis, but no intervention in active disease. And about the treatment, therapeutic management is challenging. Takayasu in children majority suffer from progress or relapsing types of the disease and requires immunosuppressive therapy to control vascular inflammatory. So if we delays of diagnosis and delays of treatment may cause irreversible vascular damage. We can see this research in elder Takayasu, nearly 50% of patients with Takayasu with relapse of a vascular complication under 10 years from diagnosis. How to assess activity? I think this is very challenging for us because systemic inflammatory response not always correlates inflammatory activity in vessel wall and may be active vasculated despite a normal ESR and CRP level and vice versa. Absent systemic clinical feature not exclude ongoing vascular inflammatory and also present ischemic symptom always such as active inflammatory. There are some recommend by APLAR about the access active disease of large vasculitis we can use. About the research in children's onset Takayasu, we can see they found that 30% of patients resistant to therapy or relapse. To compare the effectiveness of tocilizumab and TNF in treatment Takayasu, they found that the similar evidence of treating Takayasu efficacy in both. But the tocilizumab demonstrates superior efficacy and better safety than cyclophosphamide. In children, we can see the TNF was frequently preferred than tocilizumab, and in all anti-TNF, infliximab almost used, though some adverse reaction. Refers IV or subcutaneous tuberculosis. One research gives conclusion that prefer IV option for long-term maintenance of remission and reducing the risk of relapse. And we can other options to treatment for patient with Takayasu is drug inhibitor in case of refractory to biologics. This is on my discussion today. Thank you for your listening.
Okay, thank you very much, Dr. Lee, for your presentation. I think it's perfectly supplemented to Dr. Nguyen presentation before that. And now we'll come back to the clinical case. I think we have some questions from our colleagues. They're concerned about some symptoms and some information about the case, about the clinical case that Dr. Nguyen already presented. Dr. Nguyen, are you there?
Yes, I'm here.
Okay. Did you have chance to look at the questions in the chat box?
Yeah.
Okay. What do you think?
Yeah. I have a question is, was there any evidence of arthritis, lower back pain?
Yeah, in your clinical case.
Yeah. My patient has arthritis too, but she have no lower back pain.
Okay. Okay.
Yeah.
I think arthritis is also can be seen in children in the childhood onset Takayasu arteritis, but it's less common compared to the adult TA. So that's one of the things make us deviation from the treatment of Takayasu arthritis and then make us to diagnose our patient a little bit later than supposed to be early diagnosed. I think there's some question about the role of the imaging technique in supporting the diagnosis and treatment follow-up for children, for Takayasu arthritis in children. What do you think, Dr. Nguyen and Dr. Lê? Do you always use the imaging techniques in your hospital, and which one would you prefer, or which one are available in your hospital?
I think Doppler ultrasound is available for all center. And I think this imaging is easier and lower price than another than MST or MRI.
Okay, Dr. Lê? How about your hospital?
In our hospital, we have CTA, MRI, and Doppler ultrasound. But normally, we use the CTA and MRI and including Doppler ultrasound to finding the signs of symptoms. We can combine the some imaging modalities to approach in a stepwise.
Okay, thank you. Yeah, I agree. I totally agree with you with your comments. I think imaging technique is very important in helping us to make diagnosis and to follow the progression of the disease during the treatment times. But it's hard. It's typical to tell that which one is better than the other one. Better than one is better than another in clinical practice, because we do not have the direct comparison study among these techniques. And one of the important thing is that whatever you use, the person, I mean that the radiologist or the doctor who do the technique, and the results explained by their performance is very important, and it depends very much on the skills and knowledge of each person. So what among the facility that we can use to support the Takayasu arthritis diagnosis and treatment, we can use either MRA or MRA or color Doppler ultrasound and CTA. But I think the important is that how good that technique performs in your institute or hospital. So we have to decide which one is better and which one is more suitable for your patients. And one of the important things that we should consider is that each technique have some advantage and some disadvantages. For example, with MRA, it is a non-invasive technique, except for the case that you need to use the magnetic resonance contrast, that you need to use gadolinium. I think it's safer than other technique compared to CTA or PET-CT. However, in some case, it's not. It cannot help to detect the lesions better than the other technique. PET-CT or CTA or CTR is very important, but it has a very high risk of the radiation exposure to the children. So it's one of the disadvantages. So I think in clinical practice we should consider the available of the facilities and the strong and weak point of each technique, so we can use it properly and safely for our patients. And to come back to your clinical case.
Sorry, Professor Hong.
Yeah.
Here is I see on Q&A box. The Professor Sumara sees the president of pediatrics, Asian rheumatologist. Sister
Okay.
asked, yes, We taught on whole body MRA or PET-CT to screen for active vasculitis. And I can answer her questions that because in our countries and in our hospital, we haven't got the whole body MRA. So it is the best choice we can use these techniques to discuss to find out the active vasculitis in the children with Takayasu.
Okay, thank you, Dr. Chi. And comparison between MRA and PET-CT, I think PET-CT can put some risks for our patients because I think the radiation doses that the patient exposed during the technique is it's quite high. So I think it's good. It's good technique, but compared to MRI, I think it's maybe less safe than MRI. What do you think, Dr. Chi?
Yes, I think so.
Okay, thank you.
Yes, and we can see some questions in Q&A box. That was some audience asked about the treatment. Dr. Ling Liu see us.
Okay. The questions from Dr. Which one are you? Which one do you mention, Dr. Lei? Which one? What is currently considered the best imaging, or is there any validated diagnostic scoring system? I see the two questions from Dr. Ling Liu. There's no questions related to the treatment. Okay. I think there is a very practical question about the use of corticosteroid and the tapering in order to make it safe for our children. In clinical practice, how do you use glucocorticoid for treatment of the Takayasu arteritis? And how do you reduce the dose? When and how much do you reduce during the treatment and during the follow-up time? Dr. Chi?
Yes, I think we can accept the active disease. If it is the ongoing active disease, we can pause the corticosteroid and we can use the steroids agent with TMAS. And sometimes we can, if the TMAS active, we can decrease the corticosteroid, and after that, we can assess again by clinical and by biomarker and by the image modalities to assess how active disease appears and how the important organ affected to decide the treatment.
Okay, thank you. Okay, by the way, Dr. Lei, there is a question from Dr. Syed Atihat. She would like to know what is TNF alpha inhibitor in the trials that you have mentioned in your presentation. Doctor, I think both of you mentioned the use of biologic, including TNF alpha inhibitor in your presentation. Could you please explain a little bit more? What kind of TNF alpha in the trials?
In our hospital, we have both TNF inhibitor, infliximab or adalimumab, and depend on our patient, we can choose which one.
In the trial, in the trial that you cited in your presentation, I think the several in TNF alpha inhibitor have already been trialed in children, including infliximab, as Dr. Chi said. And how about golimumab, Dr. Chi? Is there any trial on the golimumab?
Not
or
yet.
other TNF alpha?
Yes, not much. Not here. Not yet in my hospital. Golimumab.
Okay. How about you, Dr. Nguyen? Dr. Ha Nguyen?
Yeah.
What kind of TNF alpha inhibitor that have been trialed in children?
We use tocilizumab, adalimumab,
Okay.
available in my hospital. Yeah.
And if infliximab in the trial, I see that they already published the trial, the clinical trial on those in TNF alpha inhibitor, as you mentioned, together with tocilizumab and other medication. But I think mostly the trial and the recommendation for biologic treatment in children is tocilizumab and is interleukin-6 inhibitor and TNF alpha inhibitors. Okay.
And I have another question from Dr. Elizabeth Ang. She's my teacher in Singapore.
Okay, I think there are questions for both of you.
Yeah.
Do you have any difficulty in treatment of childhood Takayasu arthritis in Vietnam?
Yes, I think in my hospital there are many challenges in treatment of Takayasu, particularly in children. Very many patients with hypertension not respond with medical therapy alone, but sometimes patient also include T-spot positive, so we couldn't treatment aggressive at that time. We have to treat combined tuberculosis and a minor dose of corticosteroids. And after 1 month of treatment tuberculosis, we can add other immunosuppressant therapies.
Okay, thank you, Dr. Lee. I think there are still some more very interesting and very good questions in the chat box. But I'm afraid that we only have a few minutes left, and due to the time limitation, so I think we will close our question and answer here, because we still have some information to share you later on. And I would like to ask APLAR secretary to collect all these questions and send to our group, and we'll prepare and answer directly to the college that who put the question in later when we're ready for that. I would like to have some information about the ground route activity that we have been doing so far. You know that, as I mentioned earlier, APLAR Ground Route is a program to promote the education and training activity in the Asia Pacific region. And in addition to Ground Route, APLAR Academy also have other activities such as Grand Round Forum and APLAR Blackboard. And in the APLAR Grand Round Forum, it is actually a website, a online platform that allow all of us to interact, to participate and to interact. You can share your knowledge, exchange your ideas, and give comments and experiences about the APLAR Academy. All attendants are invited to write in the forum around the theme of the Grand Round, and you simply browse the following address: https://aplar.org, and look for Academy, then Grand Round, and upcoming Grand. Then you can see APLAR Grand Round Forum. About the APLAR Blackboard, APLAR Blackboard is actually the place that you can check yourself, your knowledge, your experiences, and your understanding about the Grand Rounds in general, and specific Grand Round. For example, today topic is the Childhood-Onset Takayasu Arteritis, importance of early recognition, and we already have some questions on the topic and related to the clinical presented today, and you can log in and you can answer the question with the detailed explanation. Similarly, you can browse the APLAR website and then look for Academy, then Grand Round, then upcoming Grand Round, and then APLAR Blackboard, and you see what you can do. And before you leave the Grand Round, please give us support by giving your comment, your idea, any idea, anything you are thinking and you think that we can improve Grand Round activities and to help APLAR working better to help each other to develop rheumatology in the regions. Simply scan the QR code on the screen, and then you can it will lead you to the website that you can give your comments and ideas and your thinking. So thank you very much for all of you to spend time to join the Grand Round today, and we hope that we will have more program coming up, and please reserve time and the table, your timetable, and arrange your work and your time to participate in our activity in the future. Thank you.
Thank you so much, Professor Hong, and thank you so much for all attending. I can see many teachers and many friends in Chatbook, but sorry, there are many questions I haven't answered today. Yes, thank you so much for your attending to support my team. Thank you so much.
Thank you, Dr. Lê. We are understanding. Thank you.
Thank you so much.
Thank you. Bye-bye.